ATLS, Initial Assessment and Management, Formal Q&A. Welcome to the Everything Surgery podcast. Today we ask 100 essential questions on the initial assessment and management of the trauma patient from the ATLS guidelines. Pause the video when you hear the word answer to attempt answering the question. Let's begin. Question: what is the primary goal of the Advanced Trauma Life Support Protocol? Answer: the primary goal of the Advanced Trauma Life Support Protocol is to provide a standardized, systematic approach for the early care of trauma patients, with the objective of identifying and treating immediate life-threatening injuries first. Question: what is the concept of the golden hour? Answer: the golden hour refers to the principle that rapid, definitive intervention within the first hour after a traumatic injury significantly improves the patient's chances of survival. Question: what are the three phases of trauma care in the hospital? Answer: the three phases are the primary survey, the secondary survey, and definitive care. Question: what is the number one rule in trauma resuscitation? Answer: the most important rule is to always treat the greatest threat to life first. Question: what should the trauma team do before the patient arrives? Answer: the trauma team should prepare by assigning roles, donning personal protective equipment, warming the room, and ensuring all necessary equipment is ready and functional. Question: what does ABCDE stand for in the primary survey? Answer: ABCDE represents airway with cervical spine protection, breathing, circulation with hemorrhage control, disability, neurological status, and exposure and environmental control. Question: what is the most important principle of the ABCDE approach? Answer: the guiding principle is sequential evaluation and treatment. You must resolve life-threatening issues in each step before proceeding to the next. Question: what is the single most important step in the primary survey? Answer: securing a definitive airway if the patient cannot maintain it independently. Question: when assessing the airway, what is the first question to ask? Answer: the initial question is the patient talking? Because a clear voice generally indicates a patent airway at that moment. Question: what are signs of an inadequate airway? Answer: signs include obvious obstruction, stridor, snoring, gurgling, paradoxical chest wall movement, agitation, which can indicate hypoxia, and cyanosis. Question: what simple maneuvers can initially open an airway? Answer: the jaw thrust or chin lift maneuvers are employed to open an airway. Question: why is the jaw thrust preferred in trauma patients? Answer: the jaw thrust maneuver is preferred because it minimizes manipulation of a potentially injured cervical spine. Question: what is the first step for a patient with a compromised airway? Answer: the first action is to suction the airway to remove blood, vomitus, or secretions. Question: what defines a definitive airway? Answer: a definitive airway is a cuff tube placed in the trachea and connected to oxygen. Question: what is considered the gold standard for securing a definitive airway? Answer: the gold standard is rapid sequence intubation with inline stabilization of the cervical spine. Question: when is a surgical airway indicated? Answer: a surgical airway is indicated in scenarios where you cannot intubate and cannot oxygenate, such as severe maxillofacial trauma or airway obstruction that cannot be relieved by other means. Question: what are the two primary surgical airway options? Answer: the options are cricothyroidotomy, preferred in emergencies, and tracheostomy, which is performed in the operating room. Question: what is the most important rule during airway management in trauma? Answer: always assume a cervical spine injury in any multi-trauma patient and maintain inline stabilization until it is definitively ruled out. Question: after ensuring the airway is secure, what must be verified? Answer: you must confirm that the endotracheal tube is correctly positioned, usually by end-tidal carbon dioxide detection, bilateral breath sounds, and chest radiograph. Question: how is breathing assessed in trauma patients? Answer: breathing is assessed by looking for chest rise and fall, symmetrical expansion, tracheal position, and chest wounds, listening for the presence and equality of breath sounds, and feeling for crepitus and subcutaneous emphysema. Question: what are the immediately life-threatening thoracic injuries? Answer: these include tension pneumothorax, open pneumothorax, massive hemothorax, and flail chest. Question: how do you clinically diagnose a tension pneumothorax? Answer: a tension pneumothorax is diagnosed by respiratory distress, low blood pressure, absent breath sounds on one side, tracheal deviation, and distended neck veins. Immediate treatment is necessary and should not wait for imaging. Question. What is the immediate treatment for attention pneumothorax? Answer. The initial treatment is needle decompression at the second intercostal space in the midclavicular line, followed by chest tube placement. Question. How do you manage an open pneumothorax? Answer. Apply a 3-sided occlusive dressing and insert a chest tube at a site remote from the wound. Question. What defines a massive hemothorax? Answer. A massive hemothorax is defined as 1,500 milliliters of blood on initial chest tube insertion or more than 200 milliliters per hour ongoing. Question. What is the first step for external hemorrhage control? Answer. Direct pressure is the initial step, with tourniquets reserved for life-threatening extremity hemorrhage. Question. What are the 5 sites of major blood loss? Answer. The 5 sites are chest, abdomen, pelvis, thighs, from long bone fractures, and external losses. Question. What is the role of the focused assessment with sonography in trauma exam in the primary survey? Answer. The focused assessment with sonography in trauma exam is used to rapidly identify free fluid, such as blood, in the pericardium, abdomen, and pelvis at the bedside. Question. What are the indicators for immediate blood transfusion? Answer. Hemodynamic instability is the main indicator, with type O negative or type-specific blood used initially. Question. What is damage control resuscitation? Answer. Damage control resuscitation involves permissive low blood pressure, targeting a systolic blood pressure of 80 to 90 millimeters of mercury, unless there is a traumatic brain injury, and balanced transfusion of blood products in a 1:1 ratio of packed red blood cells, fresh frozen plasma, and platelets. Question. What are the classes of hemorrhagic shock? Answer. Class 1 is less than 750 milliliters. Class 2 is 750 to 1,500 milliliters. Class 3 is 1,500 to 2,000 milliliters. And Class 4 is more than 2,000 milliliters of blood loss. Question. What is the lethal triad of trauma? Answer. The lethal triad consists of acidosis, hypothermia, and coagulopathy. Question. How do you prevent hypothermia in trauma patients? Answer. Prevent hypothermia by warming the environment, using forced air warmers, and warming all intravenous fluids and blood products. Question. What are the 2 preferred sites for large bore intravenous access? Answer. The antecubital veins are preferred. If these are inaccessible, intraosseous access should be considered. Question. How is the neurological status rapidly assessed? Answer. Neurological status is quickly assessed using the Glasgow Coma Scale or the Alert, Voice, Pain, Unresponsive Scale. Question. What does alert, voice, pain, unresponsive stand for? Answer. It stands for alert, responds to voice, responds to pain, and unresponsive. Question. What is the most common cause of neurological decline in trauma? Answer. The most common causes are low oxygen and low blood pressure, which should be corrected before assuming a primary brain injury. Question. What is the single most important clinical sign in head injury? Answer. A decreasing level of consciousness. Question. What must be checked after stabilizing airway, breathing, and circulation? Answer. Pupil size and reactivity should be assessed. Question. What does exposure mean during trauma assessment? Answer. Exposure means completely undressing the patient to allow a full visual inspection for all injuries. Question. What is the critical action after exposure? Answer. The critical action is to prevent hypothermia by covering the patient with warm blankets after the examination. Question. What must be done during the exposure phase? Answer. The patient should be log-rolled, with cervical spine stabilization, to inspect the back and perform a rectal examination. Question. What is assessed during the rectal examination? Answer. Assess rectal tone for spinal cord injury, presence of blood, and prostate position. A high-riding prostate suggests possible urethral injury. Question. What are standard monitoring adjuncts during trauma assessment? Answer. These include electrocardiogram, pulse oximetry, blood pressure measurement, end-tidal carbon dioxide monitoring, Foley catheter, and nasogastric tube. Question. When is a Foley catheter contraindicated? Answer. A Foley catheter should not be inserted if there is blood at the urethral opening or a high-riding prostate on rectal examination. A retrograde urethrogram must first be performed. Question. When is a nasogastric tube contraindicated? Answer. A nasogastric tube is contraindicated if a basilar skull fracture is suspected, such as with cerebrospinal fluid rhinorrhea, raccoon eyes, or Battle's sign. In such cases, an orogastric tube is preferred. Question: what imaging is considered part of the primary survey in blunt trauma? Answer: chest radiograph, pelvic radiograph, and lateral cervical spine radiograph are considered standard, though computed tomography now largely replaces these. Question: what is the most important initial blood test in trauma? Answer: type and cross-match for blood products is the most important initial test. Question: what is included in the trauma panel of blood tests? Answer: the panel typically includes complete blood count, basic metabolic panel, liver function tests, coagulation studies, lactate, blood gas analysis, and beta-human chorionic gonadotropin. Question: when does the secondary survey begin? Answer: the secondary survey begins only after the primary survey is complete and resuscitation is well underway. Question: what is the goal of the secondary survey? Answer: the goal of the secondary survey is to obtain a complete history and perform a head-to-toe physical examination in order to identify all other injuries. Question: what is the ample history? Answer: ample history stands for allergies, medications, past medical history, last meal, and events surrounding injury. Question: what is the first part of the head-to-toe examination? Answer: the first part of the head-to-toe examination is to record full vital signs and assess the Glasgow Coma Scale. Question: what must be palpated during the head examination? Answer: during the head examination, the entire scalp must be palpated for lacerations and bony step-offs. Question: what are signs of a basilar skull fracture? Answer: signs of a basilar skull fracture include periorbital ecchymosis, also known as raccoon eyes, mastoid ecchymosis, also called Battle's sign, cerebrospinal fluid rhinorrhea or otorrhea, and hemotympanum. Question: how is the chest examined? Answer: the chest is examined by inspection, palpation for crepitus and tenderness, and auscultation of the heart and lungs. Question: what is the most sensitive part of the abdominal exam? Answer: the abdominal examination is not sensitive. Serial examinations are essential. Unexplained hypotension should be considered hemorrhage until proven otherwise. Question: what is the role of diagnostic peritoneal lavage? Answer: diagnostic peritoneal lavage has largely been replaced by focused assessment with sonography for trauma or computed tomography. However, it may be used in unstable patients with an equivocal focused assessment with sonography for trauma. Question: how is the pelvis assessed? Answer: if a pelvic fracture is suspected, the pelvis should not be sprung. Instead, the iliac wings should be gently compressed inward. Question: what is the first sign of a compartment syndrome? Answer: the first sign of a compartment syndrome is pain out of proportion to the examination and pain with passive stretching of the muscles in that compartment. Question: what is a key part of the neurological examination? Answer: a key part of the neurological examination is to assess motor and sensory function in all four extremities to evaluate for spinal cord injury. Question: what is the final phase of the advanced trauma life support protocol? Answer: the final phase is definitive care, which involves transfer to the operating room, angiography suite, intensive care unit, or another facility. Question: what are indications for immediate transfer to the operating room? Answer: indications for immediate transfer to the operating room include hemodynamic instability with a positive focused assessment with sonography for trauma, evisceration, uncontrolled external hemorrhage, or limb-threatening injury. Question: what are indications for transfer to a higher level of care? Answer: indications include the need for capabilities not available at the current facility, such as neurosurgery, cardiothoracic surgery, or a burn unit. Question: what is the most important document for transfer? Answer: the most important document is a copy of all records and imaging, as well as a detailed transfer note with vital signs and interventions. Question: what is unique about pediatric patients? Answer: pediatric patients compensate well for blood loss, with tachycardia as an early sign, but deteriorate quickly. A pediatric weight tape, such as a Bracelo tape, should be used. Question: what is unique about pregnant trauma patients? Answer: the best way to save the fetus is to save the mother. After 20 weeks of gestation, the board should be tilted 15 to 30 degrees to the left to relieve aortocaval compression. Question: what is unique about geriatric patients? Answer: geriatric patients have less physiologic reserve. Normal vital signs may mask significant shock, so there should be a low threshold for aggressive workup. Question: why are elderly patients on beta blockers a concern? Answer. Elderly patients on beta blockers may not develop tachycardia in response to hemorrhage, which can give a false sense of security. Question. What is the number one cause of preventable death in trauma? Answer. The number one cause of preventable death in trauma is failure to secure the airway. Question. What is the second most common cause of preventable death in trauma? Answer. The second most common cause is failure to recognize and treat hemorrhagic shock. Question. What is the most common sign of shock? Answer. Tachycardia is the most common sign of shock. Question. What is Cushing's triad? Answer. Cushing's triad consists of hypertension, bradycardia, and irregular respirations, and is a late sign of increased intracranial pressure. Question. What is the minimum Glasgow Coma scale for a patient to usually protect their airway? Answer. A Glasgow Coma scale of 8 or less typically requires intubation for airway protection. Question. What is the first sign of a pneumothorax on a supine chest X-ray? Answer. The first sign is the deep sulcus sign, which is a very lucent costophrenic angle. Question. What is Kerr's sign? Answer. Kerr's sign is left shoulder pain referred from diaphragmatic irritation, such as from a splenic injury. Question. What is Gray-Turner's sign? Answer. Gray-Turner's sign is flank ecchymosis suggesting retroperitoneal hemorrhage. Question. What is Cullen's sign? Answer. Cullen's sign is periumbilical ecchymosis, also suggesting retroperitoneal hemorrhage. Question. What is the seatbelt sign? Answer. The seatbelt sign is an abdominal wall contusion from a seatbelt and is a marker for internal injuries such as bowel injury or a chance fracture. Question. What is the first step if a patient crashes during the primary survey? Answer. The first step is to re-evaluate the airway, breathing, circulation, disability, and exposure to find a missed life-threatening injury. Question. What is the most common injury missed on initial assessment? Answer. The most common missed injury is posterior hip dislocation. Question. What is the most common cause of death in trauma? Answer. The most common cause of death in trauma is traumatic brain injury. Question. What is the single most important treatment for traumatic brain injury? Answer. The single most important treatment is to prevent hypoxia, with oxygen saturation above 90%, and hypotension, with systolic blood pressure above 90 mm of mercury. Question. What is the role of intravenous mannitol or hypertonic saline in traumatic brain injury? Answer. Intravenous mannitol or hypertonic saline should be administered for signs of brain herniation or acute neurological decline due to elevated intracranial pressure. Question. What is the trauma triad of death? Answer. The trauma triad of death consists of hypothermia, acidosis, and coagulopathy. Question. What is the target temperature for a trauma patient? Answer. The target temperature is above 36 degrees Celsius, or 96.8 degrees Fahrenheit. Question. What is the target for pH resuscitation? Answer. The target pH is greater than 7.2. Question. What is the target for base deficit? Answer. The target is for the base deficit to improve towards normal. Question. What is the target lactate? Answer. The target lactate is below 2.0 millimoles per liter and trending downward. Question. What is the role of tranexamic acid? Answer. Tranexamic acid should be given within 3 hours of injury to bleeding trauma patients. Question. What is the shock index? Answer. The shock index is the heart rate divided by the systolic blood pressure. A value greater than 0.9 suggests shock, and a value greater than 1.2 suggests significant hypovolemia. Question. What is the first sign of a tension pneumothorax in a ventilated patient? Answer. The first sign is an abrupt increase in peak airway pressures. Question. What is the most common cause of cardiac arrest in trauma? Answer. The most common cause is hypovolemia. Question. What is the only absolute contraindication to emergency department thoracotomy in penetrating trauma? Answer. The only absolute contraindication is decapitation. Blunt trauma with more than 10 minutes of cardiopulmonary resuscitation without signs of life is a relative contraindication. Question. What is the primary goal of an emergency department thoracotomy? Answer. The primary goal is to relieve cardiac tamponade and control cardiac or thoracic hemorrhage. Question. What is the first thing to do after opening the pericardium in an emergency department thoracotomy? Answer. Control cardiac wound hemorrhage with a finger or staple. Question. What is the most common complication of a chest tube? Answer. Malposition. Question. What is the single most important principle after the primary survey? Answer. Frequent re-evaluation. The trauma patient's condition can change rapidly. Question: what is the ultimate measure of a successful resuscitation? Answer: a patient who leaves the hospital neurologically intact. That's it. Thanks for tuning into today's episode. If you have any questions, leave it in the comment section. If there are any topics you are interested in seeing on this channel, state it in the comment section. If you enjoy the video, remember to like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.